Hey, Jerry Pal listeners. We're about to celebrate our 100th episode. Help us out and call 929-JERRY-PAL to tell us one thing you've learned or loved from the podcast in 15 seconds or less. Your message might make it on air. Again, that's 929-437-4725.
Welcome to the Jerry Pal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, who do we have in the room with us today?
In studio today, we have... Oh, no. I don't know how to say your last name, Anil.
Makam.
Anil Makam. All right, Anil Makam, who is a hospitalist and researcher at the Chan Zuckerberg San Francisco General Hospital.
Chan Zuckerberg.
The Chan Zuckerberg San Francisco General Hospital.
Did Mark Zuckerberg change his name?
No. It's Priscilla Chan. She's a UCSF doc.
Ah.
Right? Isn't
That's
she?
right.
Welcome to the Jerry Pal podcast.
So we got to call it the CZSF.
The CZSFGH.
That's too many the general.
The General Hospital. And we're going to be talking about L-tacs, or long-term acute care hospitals. Did I get that abbreviation right?
That's right.
I think it's Ltac.
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 Yeah,
Never heard that before?
Yeah, the cool kids say LTACs.
Ltac.
L-tacs. What they are, who goes to them, and what happens to these people. But before we do, we always ask for a song request. Do you have a song for Alex?
We do. In honor of where this research came from, deep in the heart of Texas. The de facto state song.
Are you going to sing along with Alex?
I will try.
Okay.
Perfect. The stars at night are big and bright. Deep in the heart of Texas, the dark prairie sky is wide and high. Deep in the heart of Texas, the sage in bloom is like perfume. Deep in the heart of Texas, reminds me of the one I love. Deep in the heart of Texas. Woo!
That was fabulous. Texas. This started off in Texas?
Where my research career started and where the idea to study LTACs came from. Was practicing in Texas and then moving to San Francisco, and it's black and white in terms of post-acute care use.
Go ahead, Alex.
I was going to say, what do you mean by black and white in terms of post-acute? Well, we should back up. Shouldn't we talk about what is an LTAC?
Okay. What is an LTAC?
So an LTAC briefly is a post-acute care hospital for people who survive an acute or serious illness in a hospital, but still need on the order of 3 to 4 to 5 weeks of more hospitalization and aren't ready to go home and are too sick to go to a skilled nursing facility.
Okay, so what's the difference between that and a skilled nursing facility?
So it's closer to a hospital. Nurses have smaller patient-to-nurse ratios. Physicians see patients daily as opposed to skilled nursing facilities where they're mandated once every few weeks and more so if people are sick. Also in LTACs, there's a multi-physician specialty available on a daily basis. Some have small operating rooms. They have an ICU. They have usually a CAT scanner. And they have ability to do laboratory tests as needed.
Is this the same thing as a vent facility?
Good question. That's where they originated from in the 80s. They started as vent hospitals and morphed into more general, broad post-acute care hospitals.
And the difference between this and acute rehab?
So here they're focused on medical care as well as rehab and not solely on rehab. Which is the main distinction. They don't have to have 3 hours of rehab a day, which is one of the criteria to go to an inpatient rehab hospital.
So LTAC, and you said earlier that it's black and white as far as the difference between Texas and California in terms of LTAC facilities. Can you expand on that?
Yeah, so it's more so between Dallas-Fort Worth as compared to the Bay Area. So in the Dallas-Fort Worth Metroplex, when I was practicing there, we had on the order of 20 to 25 LTAC hospitals. And it was normal for people after they were recovering from the hospital to go to an LTAC to recover. In San Francisco, if you include Marin County, San Francisco, the South Bay, the East Bay, even all the way out to Sacramento, there's about 4 LTAC hospitals.
Oh, that's it.
That's right. So it's not part of the normal part of post-acute care, at least in the Bay Area.
So is that because we keep our patients healthier until they're discharged from the hospital?
It's all the kale that we eat.
That's right.
I think it's just representative of just how different markets think of post-acute care. Interestingly, about 3/4 of the variation in the Medicare spending is attributed solely to post-acute care. So this is reflective, I think, of the national experience. Some places use more expensive post-acute care settings, like L-tacs. Other places keep people in the hospital longer or send them to skilled nursing facilities.
So over 2/3 of the geographic variation.
3/4 of the geographic variation in Medicare spending is due to how different places use post-acute care.
And L-tacs are much cheaper than skilled nursing facilities.
We would hope so, but you'd think, far more expensive. So for the same diagnosis, it's about 3 to 5 times more expensive than a skilled nursing facility.
L-tac is 3 to 5 times more expensive than a skilled nursing facility for the same diagnosis.
Yep.
Whoa! Why do states have these? What's going on in Texas?
So it's a good question.
I like it big in Texas.
Actually, the regulation in Texas and California are the same, as in we don't have certificate of need laws in either state.
Wait, what?
Meaning that if you wanted to open a new hospital or an LTAC, certain states actually require you to make a case, which is a certificate of need. I was actually surprised California doesn't have a certificate of need requirement either to open up facilities.
And LTACs are basically regulated like a hospital because it is a hospital, right?
It is a hospital.
Long-term care hospital.
So hospitals are have to meet criteria by CMS, which is the Centers of Medicare Medicaid. So LTACs have to meet the exact same criteria as acute care hospitals or traditional hospitals, which most people are familiar with, except the only distinction is they have to have an average length of stay of 25 days for their population.
So that's the long-term care part. So the long-term acute hospital part is that you have to have a length of stay of 25 days.
Yeah, it's a little bit like jumbo shrimp, an oxymoron, the long-term acute part. So these are people who have acute needs, but they need to be there for, on the order of several weeks.
So should we think of them, for those of people who haven't been in one, should they think of them sort of like an ICU light or more like an intense skilled nursing facility?
When used appropriately, I think the best comparison are ICU/step-down hospitals. So once people recover from the ICU but still have acute needs, as well as ICU level care as well.
Okay. How did you get interested? Like, what's the nidus for this? Like,
so when I was a fellow here, a lot of my colleagues used to moonlight in L-tacs. So the funny thing, I was looking for moonlighting opportunities as a fellow to afford San Francisco rent. And people looked at me like I had like 2 heads on my shoulder when I said, oh, where do people moonlight? And I just kind of threw out L-tac because that was like a familiar setting to me. And they're like, what the heck's an L-tac? And then when I went back to Texas on faculty, that idea kind of just stayed with me because I've taken care of sick old people in both places. But for some reason, the way we think about post-acute care was very differently in different markets.
And you had a previous paper in the Journal of American Geriatric Society, JAGS, that showed that the use of L-tacs is determined mainly by geography. Is that right? Or a lot of the variation? A lot
of the variation. Not mostly. Half of the variation in who goes to an LTAC is still driven by how sick people are and what their care needs are. But if we think about variation in other things in healthcare, 50% is pretty low. If you think about what's the variation in inpatient mortality or inpatient Medicare spending, like less than 10% of the variation is explained by things other than how sick people are. So that's a lot of variation that's not explained by how ill people are and what they actually need. About 1/3 of the variation is just what region in the country you're in. And 15% of the variation is what hospital you're in before you go to an LTAC.
Oh, so some hospitals tend to send patients to LTACs and some hospitals tend not to.
Exactly. So if you're in a market with a lot of LTACs, you could be at a hospital that preferentially sends people there, or you can be in a hospital that rarely uses it, even with the same access.
There must be some reason for some regions and hospitals linking up with LTACs and others not. It doesn't have to do with money, does it?
I've never been able to really answer this. I've talked to researchers and some industry insiders. And the best answer I can get to is just some places have an appetite for them and have experience. There's some upfront construction costs and maintenance costs. I think it's a lot more expensive to maintain a hospital in San Francisco than it is Dallas. But that's not the full story. So it's not really clear why some places have a ton of these and some places don't.
Does it matter at all if you have an LTAC within your hospital or outside of your hospital?
So CMS has tried to draw that distinction. If you have some hospitals, some LTAC hospitals are considered hospital within hospitals where they lease a floor within a traditional hospital. And then about half the LTACs are freestanding facilities, just like a traditional hospital. So CMS tries to say, to limit self-referral, that you have to have separate management for the LTAC. They can't be affiliated in any way, shape, or form. And then there used to be, I don't know how strictly it's enforced, but only a certain percentage of their population can come from the hospital that they're leasing.
But there's still that financial relationship of you have this potentially lucrative lease, and you want that lucrative lease to stay probably.
So one of our main findings in our variation work is proximity to the nearest LTAC from where you're hospitalized. So we would consider that a 0 mile distance if you're located in the same place. And that's one of the strongest predictors of who goes to an LTAC.
How close you are.
How close you are. So if you're in a building with an LTAC, some of this might be just familiarity. Some of the reason could actually be good intentions, continuity. Sometimes specialty physicians might still go and consult on their patients who move from one floor to the other.
Now, earlier you said that the patients who go to the LTACs are patients who need more time in the hospital. But they only need more time in the hospital if their goals are aligned with acute type of care, intensive care, they get a trach and a peg and they are comfortable being ventilated and weaned from the ventilator, though that may take months but they've all had discussions about prognosis, I'm sure, and know what's ahead for them and are fully informed as they're making these decisions to go to an LTAC. Is that right?
You sound very optimistic. That's the idea. Before you go to any, the next setting, the hope is, especially if you're that sick, people have had discussions with their doctors, with their loved ones, and have thought about kind of what they're willing to live with, what kind of life is acceptable, what kind of impairments are acceptable, what kind of care is aligned with their goals. So that's something that in the current paper we get at not directly but indirectly, and something that I've become increasingly interested in looking at.
So let's talk about the current paper. So you just published a paper about a month ago in the Journal of American Geriatric Society, JAGS, titled "The Clinical Course After Long-Term Acute Care Hospital Admissions Among Older Medicare Beneficiaries." I did not memorize that. Alex is holding up the paper for those who are watching on YouTube. It is an absolutely fabulous paper, and it gives us a sense of who are these people and what happens to them in LTACs. Like, are they getting better? And for most people, I think probably the goal is let's get my loved one home. I want to go home. Are these people actually going home? What's happening to them? And overall, are they getting better? What did you find? Are they getting better when these people are going to LTACs?
Yeah, so we looked at a sample of Medicare beneficiaries using the national Medicare data set. We looked at how people did up to 5 years after they go to an LTAC hospital. We followed them out for whether they lived or died. We looked at their inpatient utilization burden, and we looked at whether people made it quote unquote home, even though we don't actually know they went home. And we found that Unsurprisingly, mortality rates are really high. So about fewer than 1 in 5 older adults are alive 5 years after they go to an LTAC.
Fewer than 1 in 5 are alive. How many years?
Up to 5 years.
Up to 5 years after an LTAC.
And the 1-year mortality is fairly high. A little over half of older adults die by 1 year.
Wow.
I think what stood out to me most was just the intensity of care people received after they went to an LTAC.
And you had one of the most beautiful diagrams. I swear I stared at it for like a half an hour. It was a heat map looking at each line was like individual patients. And you can actually see black was if they died, orange was they're in the LTAC, and you can actually see for these individuals like who survived. So 40% survived at 1 year. You can see they were in the LTAC, and then the color turned gray, which is that they went home, and then they went to the hospital, and they went home, and they went to the hospital, and they went home, they went to the hospital, they went home, and like just a cycle just continued. And those were like for the people who did the best after LTAC versus, half of them died, and those people looked like most of their time in an inpatient facility. Is that right?
Yeah. Thank you for highlighting our figure. I spent a lot of time trying to tell the story.
I love that figure. It is something that all of our listeners should check out. It's one of those things that you can just stare at and stare at and stare at and learn more and more about.
Right. If you're interested in the visual display of quantitative information, this is a figure you need to see. This really conveys the message.
Well, it's interesting. For like the first 30 seconds, I'm staring at them all. What am I staring at? And then you start realizing that these colors like are, oh my God, that's a hospital stay, that little band of red. That's that big black splot.
They should have printed it bigger though. They should have been a half a page.
If you actually go online, you can actually pull out the big graph, which is really amazing to look at. We'll have a copy of it attached to the show notes of this podcast.
I was glad at least JAGS published in color. It doesn't do it justice when it's in black and white.
No, that would be very boring.
So I'm a health services researcher, and I focus on a lot of kind of comparative effectiveness research techniques. But I personally think that sometimes telling the best story is just in the descriptive data. So we used claims data and pieced together where people were every single day after they went to an LTAC, just based on the dates of their claims. And we tried to tell the story of what happens to people using a 30,000 foot data set without actually interviewing and talking to people.
Yeah. And I think that's the important part. Just knowing like half died doesn't tell the story. Knowing that what was their median survival?
So median survival 8 months for all comers.
Jesus, that's worse than almost every cancer out there now.
Yeah, so
I guess like pancreatic cancer. That's probably about the same median survival.
Yeah, with current treatments.
Yeah, and then we can get into it more, but in the population, that's probably going to be more representative of LTACs moving forward. It's a median survival of a little over 6 months, which is close to the hospice criteria.
That is basically anybody who's eligible for an LTAC is eligible for hospice.
Now, presumably these people who are going to these LTACs they have a goal that's different from people who are going home with hospice.
Yes.
In some sense. Their goal is to receive this aggressive treatment in the hopes of living longer, and for many of them, hopefully, returning to better function and to get home.
I would say a slight twist is that's the goal of the care. We actually don't know if that's the goal of the patient.
Well,
we're assuming it's the goal of the patient.
Well, I would argue if the variation is dependent on proximity and geography, sure, maybe some of that is related to like maybe people in different proximities to an LTAC have different goals, but that certainly would be weird if they're all geographically kind of in the same city and that variation. It argues like from the Dartmouth Atlas literature too is preferences for care don't really matter. It's the systems that we build that determines what kind of care we get.
Yeah, I mean, I think that's an interesting hypothesis that.
Damn it, it's a hypothesis.
I mean, we don't know because nobody has ever actually went into these facilities and spoken to people, or even before they leave the facility. Is this the care they want? We're assuming that this is the care and aligned with their goals because these are hospitals. They're not hospice facilities. They're not intended to focus on quality and to transition from less intensive care.
Huh.
Yeah, so I'm wondering what proportion lived less than 6 months.
What proportion?
I don't know. You probably don't know that off the top of your head, but it'd probably be something like a third.
Probably. So a third of the people never make it home. They don't necessarily die in the LTAC, but they'll go from an LTAC to a hospital, maybe back to the LTAC or a skilled nursing facility, and they'll die somewhere along kind of this continuum of care. We know kind of the average median survival is 6 to 8 months, depending on if you're thinking the older LTAC population compared to the LTAC population of the current.
So these people are seriously ill. They're in these LTAC facilities. They're older. These are Geri-Pal patients, right? I'm so relieved that we have robust palliative care services in all of these LTACs.
Are they getting palliative care? Have they?
Our study would argue very little penetration of palliative care, if you believe how we define palliative care, which I think is reasonable. So we use Medicare billing data, physician pro fees or professional fees, which is in the Medicare Part B data. So Medicare requires physicians to designate their specialty. So if you're a palliative care physician and you want to bill and you're part of the same group as a group of internists and you're both seeing a patient and you both submit bills on the same day to differentiate your care from your colleague's care who's in your group, you would submit a designation that says you're a palliative care physician, so both of you get paid.
So if before the LTAC, I saw a patient as a palliative care physician in the hospital, that would have been captured by this definition.
So it's never been validated, I should say, but I think it's a reasonable way because doctors care about how they get paid.
But we need to validate this because there's a virtual billing code for palliative care, but it's a V code, and so there's no reimbursement for it, so there's no incentive to bill for it. But it would be fascinating to validate this measure.
But if a nurse practitioner and a social worker, they saw them, it wouldn't have been captured.
Would not have been captured. So we only had physician data. So there could have been palliative care delivered by a nurse, a social worker, psychologist, other members of the team.
So how many of these patients with a median survival of 8 months saw palliative care physicians?
A whopping 1%.
1%.
One out of 100.
1 out of 100.
Yeah.
And that was at any time during their...
So only during the index episode of care, which we defined as when they're in the hospital and then in the LTAC when they get transferred.
Okay, so either in the hospital or in the LTAC.
This includes the hospital too?
This includes the hospital.
Yeah.
What? Whoa.
Yeah.
That's even worse. Oh no.
Yeah, that's not good. But you also included geriatricians too, right? You said, hey, geriatricians got some training in communication in life care. What, half of them? Like these are all Medicare patients, right?
About 4%.
4%. Hey, there we go.
So let's say like this billing code is underestimating the rates of palliative care and geriatrics by like a factor of 5. So it's actually 5% see palliative care and 20% see geriatrician. It's still abysmal.
Yeah, well,
I'm guessing that actually most of these palliative care consults happen in the hospital because penetration of palliative care into LTACs is abysmal. Like I don't know the data, but I'm trying to think of any setting that does.
Yeah, I've heard of one palliative care doc who works in an LTAC.
Yeah, it's not a common. I don't think it's a common phenomenon. Something we're actually looking at now is what's the palliative care penetration in LTACs in California. So there's a data set that's publicly available that says how many palliative care trained professionals and LTAC employees, and across the, kind of give away one of our main findings, across 19 LTACs in California, there's one palliative care social worker.
Whoa. Across 19 LTACs in California, there are no palliative care physicians, no palliative care nurse practitioners. There's one palliative care social worker.
At least employed and reported to OSHPD, which is the agency that reports on physician staffing or healthcare professional
This is really fascinating. So these are hospitals. And we're like, when we look at CAPC data around penetration of palliative care in hospitals, you can see that like over the last 15 years, penetration, like 90% of hospitals, like large hospitals, have palliative care. That data, I believe, excludes LTACs. Like nobody is looking at LTACs and the penetration is probably close to 0% for these. And part of the growth in inpatient hospital palliative care is that there was a financial incentive for hospitals. If we actually talk to patients about their goals, many times their goals are not aligned with very, very aggressive care at the cost of everything else. Is there that same financial incentive for LTACs to consider things like palliative care as a way to help people elucidate their goals, which also may come at a cost for shorter lengths of stay in LTACs?
Great question. I would say not explicitly, but as we're moving to like an ACO models or accountable care organizations, if a Medicare beneficiary is part of that, I think there would be an incentive to increase the palliative care footprint in post-acute care settings, even beyond LTACs.
Yeah, and I also look at your beautiful heat map again because I can't stop staring at the. I'm in love with your heat map. I want to print out a big version and put it on my wall.
Maybe you should marry it.
Yeah, I'm thinking about it. But it's interesting that the orange LTAC color is right about 1 month, maybe 25 days, like they disappear. Like I don't see any orange past a month. And I see a lot of orange at a month. Why is that?
So I think a lot of it has to do with patient selection as well as how LTACs are defined. So an LTAC is distinguished from an acute care hospital only by their length of stay. So their average length of stay for the entire population, so not for any individual patient, has to be 25 days to maintain certification as an LTAC.
So LTACs are master prognosticators. They know when they get a referral to see a patient, this patient will stay on average 25 days, and
must be it.
We are
couldn't
really
be that
good
they
at it
discharge
because
them at
that
30
line,
days,
like
26
Alex,
days.
take a look at this
I
line.
see it.
Like
I see the line.
It's remarkable how amazing a prognosticator.
Well, the analogy here is with the skilled nursing facility, the Medicare, post-acute skilled nursing facility benefit, where you have 100 days of coverage, but only the first 20 days are completely covered by Medicare. After that, you have a copay. And so what's the average length of stay? It's like 21 days. Right? It's right there.
Yeah, you see this huge drop-off at that.
Yeah, no, this has been looked at, and once people cross that magical threshold, the discharge rates do spike. Not as high as you actually would expect, but you might see like somewhere around 8 to 10% of people get discharged right at that kind of 25-day threshold. But yeah, so I think the sweet spot for LTACs are finding people who are sick but stable, but don't need like forever inpatient care. Those are people that I don't think LTACs are necessarily interested in caring for.
Now,
and it looks like in the heat map, they don't do that. Like I don't see, there may be an orange line in there that crosses 3 months, but I am having a difficult time seeing any of that. And again, most of them, there is that almost a wall of orange that stops at about 1 month.
Yeah, but I would say even though they might not need to be in a hospital or should be or want to be in a hospital, most of these people do go on to further post-acute care. They're not necessarily going home. They're going, the most likely destination, if they're alive, is a skilled nursing facility.
So how much of the remainder of life do they actually spend in inpatient post-acute settings?
So on average, people are spending 2/3 of their remaining life in some kind of inpatient setting, whether it's a hospital, skilled nursing facility.
Wow.
2/3.
And then a little over 1/3 will never make it home. They will not necessarily die in the LTAC, but die in some kind of hospital or inpatient setting.
Mm-hmm. Do we have a sense of what the symptom burden is for these folks in LTACs?
Not great. There's a couple small studies. The one that comes to mind is a great qualitative study of chronically critically ill patients with tracheostomies. And it's, as you would imagine, a very high symptom burden in this population.
Do we have an idea of the amount of life-sustaining or intensive life-sustaining treatments that these individuals are on, or invasive artificial life-sustaining treatments, PEGs, trachs, things like that?
We do. So we looked at the burden of artificial life prolonging or intensive therapies, and we looked at tracheostomies, Reseda dialysis, permanent feeding tubes, so not necessarily NG feeding tubes, and about a third of people get one of these, mostly in the hospital, but also in the LTAC when they go.
And from a prognosis, we talked about hospice, like these individuals, the sickest group have a median survival of 6 months, and overall the group has a median survival of 8 months. So hospice seems appropriate for most of them. While they may not be getting palliative care, do they have access to hospice, and do they use it?
I would say since they're Medicare beneficiaries, they theoretically have access to hospice, but we have found only 16% will enroll in hospice in that first year before dying. And just for comparison, in the national Medicare experience, close to half of beneficiaries will enroll in hospice at some point before they die.
And do you have an idea, like median length of stay in hospice? Because these people are... we're expert prognosticators. We know they're only going to stay in a LTAC for 30 days. So we have a really good idea of prognosis for these individuals. They must stay there longer in hospice, though. Length of stay in hospice must be longer because of expert prognostication skills.
We would hope. We're close to 10 days on average.
And that's about half of what we see in the general population of hospice.
And I'm sure you guys think the general average is probably shorter than it should be, which is around a little over 3 weeks.
Yeah.
So this is about 10 days.
Wow.
So on average. And this isn't just an issue at the LTAC. This is even after they go to an LTAC. After they leave the LTAC, this is when they're back in the hospital in a skilled nursing facility. Kind of like I alluded to, these people are spending 2/3 of their remaining life in some kind of inpatient setting. So there's a lot of opportunities and contacts along the way.
With healthcare reform and bundled payments, hospitals and health systems are increasingly responsible not just for the care in the hospital, but also for the post-acute care. And my understanding is that much of the cost savings that health systems are trying to achieve in order to meet these new bundle payment incentives is by reduction in post-acute care. So I'm wondering if there's been an impact on L-tacs in particular.
From acute care, from accountable care organizations?
Yeah, from accountable care organizations, bundled payments, healthcare reform.
I think it's influencing, and we see it in probably more the Medicare Advantage, or not seeing, but assuming, because that's not data that is available until recently. But I think the idea is accountable care organizations, their biggest impact in savings is through reduction of post-acute care, typically through skilled nursing facilities and home health. I don't think L-tacs have necessarily been on the radar.
Okay.
Largely because the population's much smaller, but if you kind of look at their subsequent utilization, I would imagine these are folks who would be in the highest spending group, quote unquote, high users of healthcare.
And Medicare is looking into L-tacs, right? You mentioned site-neutral payment policies. What's that?
Yeah, so the context here is a big boom in the industry in the 90s and early 2000s, especially as the payment changed in 2002, which reimbursed L-tacs similar to hospitals where they got bundled payments. So over the early 2000s, we saw an increasing use of L-tacs, increasing number of facilities. So as a result, CMS has passed a couple moratoriums, and then most recently instituted the first patient criteria for reimbursement for L-tacs. So it doesn't say that people can't go to an L-tac, but you have to meet certain patient criteria to get full reimbursement on an L-tac. And that started in 2016, slowly phasing in, and is fully implemented as of October 1st of this year.
And that's what I always think L-tac, somebody who we have difficulty weaning from a ventilator, let's send them to an L-tac. But that's like that is in the minority group. I think 1 in 5 patients they were mechanically ventilated, a lot of those for a short period of time, but the majority of patients, those weren't those patients, right?
That's right. One of the takeaways I hope for your listeners who aren't familiar with L-tacs is their role in post-acute care is a lot more beyond just chronically vented, prolonged mechanical ventilation. That's definitely their ideal case and what they're best suited for and where they originated from. But people on mechanical ventilators in our data is only about 1 in 5, meaning that 80% of the people in an LTAC aren't on a ventilator. But kind of as I mentioned, the new criteria, one of the criteria is having either prolonged mechanical ventilation needs in an LTAC or surviving an ICU stay in the hospital before coming to an LTAC. So we'll probably see more in the future.
So the acuity of L-tacs will go up.
It will go up. But
because right now they're taking people who are on long-term IV antibiotics or wound debridement and treatment and
exactly. I think it will go up, but not completely. So one of the quirks of how ICUs are defined by CMS is it also includes like step-down floors and telemetry. So this isn't like classical what healthcare clinicians would think of as an ICU necessarily.
Oh, wow. So TCUs, they count.
They would count as an intermediate care unit floor in the ICU definition by CMS. So they would still, I would think moving forward, we will see an increasing burden of the chronically critically ill population in LTAC. But I don't imagine that they're going to be more than a third or half of the population.
And I can't think of any palliative care study, like a randomized control trial of palliative care in LTACs or really any. Like, can you think of any?
No. None.
Are there any palliative care interventions in LTACs?
There's actually there's just not a lot of research on LTACs in general.
Yeah.
Most of the work is on vent weaning and on the chronically critically ill. How many get off a ventilator? What's their survival? Very little research is on quality of life, palliative care, goals of care.
Black box.
Call out to our listeners. Let's start figuring out this LTAC. How to actually get geriatrics or palliative care in these areas.
Anil wants to do that.
Yeah, no, it's something I've been increasingly interested and frustrated by is this study was actually kind of a prelude to a series of comparative effectiveness studies of just do LTACs offer better care and outcomes compared to the alternate settings, which is staying in a skilled nursing or staying in the hospital or going to a skilled nursing facility. So this was kind of our first study and just like what happens to people. And it was an eye opener for me. And it kind of raised a lot of the questions you guys are bringing up. Is this the care people want? What's their quality of life? What's their burden of care?
So what is the next step for you?
So looking at palliative care in the LTAC, writing a grant right now. Looking at are people aware of their prognosis? We know that people have high mortality rates. And they spend a lot of time in the hospital, but people do survive. But what is their quality of life? Do they actually recover? And then I think ultimately, are they engaged in advanced care planning? And this is kind of what I would call like tertiary prevention. My analogy to cardiovascular disease is, we think of advanced care planning in the outpatient setting when people are well and healthy. As a hospitalist, I often see people what I would call like secondary prevention when they come in sick and we have to make decisions in the hospital as well as future decisions. But this is like even after they survive a serious illness and they go to an LTAC, but there's still opportunity, I think, to engage people in advanced care planning.
Great.
That was awesome.
I
learned a ton about LTACs.
Me too. I'm worried
that they're big in Texas. Do you like that?
Deep in the heart of Texas.
Deep in the heart of Texas. Anil, thank you very much.
Anil, thank you.
Alex, would you mind? Can we have a little bit more?
All right.
Deep in the heart of Texas.
Coyotes wail along the trail, deep in the heart of Texas. The rabbits rush around the brush, deep in the heart of Texas. The cowboys cry, yippee-yi, deep in the heart of Texas. The doggies bawl and bawl and bawl, deep in the heart of Texas.
That was fabulous. Anil, big thank you for teaching me a little bit about L-tacs, and a big thank you to all of our listeners out there. If you have a moment, please, we would really appreciate our 100th episode is coming up, and if you can take a moment and call our listener line at 929-JERRY-PAL, that's 929-JERRY-PAL, and just leave a little blurb about one of your favorite episodes or something else you liked about our podcast. Thank you, everyone.
Thanks. Bye.
Thanks for having me.